Now, BLS is the first component of a code, running a code. If BLS is effective, then ACLS will be effective. You cannot have ACLS without BLS, so there must be a basic level or a basic start. We have to start with the BLS stuff, and then we transition to advanced cardiac life support. For BLS to be effective, you need at least 4 persons on the scene. So in proper EMS response system, you're not gonna see 2 people on a scene trying to run a code. That only happens in Jamaica, right? That's not something that you'll see worldwide. For BLS to be really effective, you need at least 4 or 3 persons. So team response is gonna be important. Now, introduction. Principles of basic life support were introduced in the 1960s. Specific techniques have been reviewed and revised every 5 years. Effective teamwork with good communication increases the potential for a positive outcome. Elements of BLS. BLS focuses on A, B, C, D, E's. We went through this when we covered the patient assessment chapter. Airway, breathing, circulation. Disability looks at level of consciousness, GCS orientation, and exposure is the same as a rapid scan. You expose, look for stuff. If the patient is in cardiac arrest, we use CABDE sequence. Only seconds should pass between the time you recognize a patient needs BLS and start of treatment. Brain cells die every second. They are deprived of oxygen. If patient has no pulse, combine artificial ventilation with chest compression. Cardiopulmonary resuscitation establishes artificial ventilation and circulation in a patient who is not breathing and has no pulse. Patient category number 6. However, just keep in mind for your very young pediatric population, your newborns, your neonates, your infants, they don't have to be pulseless for you to start chest compression. They need to have a pulse that's less than 60. So just remember that. Quickly identify a patient who is in respiratory or cardiac arrest and immediately begin BLS measures. BLS can maintain life for a short time until ALS measures can be started. Already emphasized this. We always start with BLS and eventually we have to transition to ALS. Components of CPR. American Heart Association chain of survival. So the first link is recognition and activation of EMS. The second link is immediate high quality CPR. So whoever contacted EMS needs to start CPR on that patient. The third link is rapid defibrillation. It would be good if a defibrillator is available. Might not be available until basic life support ambulances arrive. The fourth link is basic life support and advanced EMS. They go together. And the final link is ALS and post-arrest care, which occurs in the hospital. So for CPR to be effective, we must have proper recognition and activation. The bystanders that are activating the system must start at minimum compressions on the patient. Depending on the location that they're at, if a AED is available, that would be great. If not, they would have to wait on basic or advanced life support EMS response. and then the hospital bills on that. If there are things missing in the links, or there is a delay in the links being initiated, then the outcome of the patient will decrease. If any one of the links in the chain is absent, the patient is more likely to die. IV or IO access should be established as a fluid and medication route. Determine the possible reversible causes of cardiac arrest. So your role as the advance, you're going to be a part of the ALS response, and your responsibility is to assist with getting the patient on a cardiac monitor, establishing IV access or IO access, fluid resuscitation, and you can give epinephrine full stop. So that's it for AEMTs. Get the patient on cardiac monitor, assist to get the patient on a cardiac monitor, IV access or IO access, fluid resuscitation, epi. And this chart depicts that. So start CPR with chest compressions, administer oxygen, attach AED, check rhythm if VF or VT shock. Perform continuous high-quality CPR in 2-minute cycles until an advanced airway is inserted if needed. Then compressions are continuous at least 100 to 120 beats per minute, and ventilations are asynchronous. Establish IV, IO access, give epi, full stop. Consider advanced airway, quantitative waveform capnography, treat reversible causes, things that you can treat as a AEMT. Provide transport, return of spontaneous circulation, integrated post-arrest care, or terminate efforts per medical control. You want to perform high-quality CPR in cycles of 30 to 2 with rotating compressors every 2 minutes and at maximum of 10-second interruptions. Shouldn't exceed 10 seconds. Nice chart for you to learn. Assessing the need for BLS. Always begin by surveying the scene, determine unresponsiveness. Basic principles of BLS are the same for infants, children, and adults with a few tweaks. Cardiac arrest in adults usually occurs before respiratory arrest, and respiratory arrest usually occurs before cardiac arrest in infants and children. Very important slide. Very important statements. Automated external defibrillation. Most pre-hospital cardiac arrests occur as the result of sudden cardiac rhythm disturbances. Early defibrillation is most likely to improve survival rates. When a patient is in cardiac arrest, begin CPR and apply an AED as soon as it is available. AED usage in children. Safest if using pediatric size pads and a dose attenuating system. Apply after the first 5 cycles of CPR. For an infant, a manual defibrillator is preferred. Never cut the adult size AED pads to adjust the size. Special AED situation. Pacemakers and implanted defibrillators. Place the AED pads at least 1 inch, 2.5 centimeters away from the device. If there's issues with water, do not use the AED on unit in water. Quickly wipe off as much moisture as possible from the patient's chest. If the patient is hairy, EMS providers generally carry small razors Quickest way to remove here is to press the AED pads firmly against the chest and quickly pull them off. Transdermal medication patches, remove patch and wipe the skin to remove the medication residue. Position the patient. For effective CPR, the patient must be lying supine on a firm surface. And you will have to figure that out depending on where you are. You should have a CPR board in the back of your unit, or a short backboard can work. But you definitely want the patient on a hard surface. Do not attempt to do CPR on a patient that you find in a bed at their home. Ensure enough space for 2 rescuers to perform CPR and use the AED. One sec. All right. Checking for breathing and pulse. Visualize the chest for signs of breathing while palpating for a carotid pulse. If the patient is not breathing and does not have a pulse, begin CPR starting with chest compressions. Proper hand position. Correct hand position is established by placing the heel of one hand on the sternum in the center of the chest. Compression technique. Motions must be smooth, rhythmic, and uninterrupted. Short jabbing compressions are not effective. Push hard and fast and switch compressors every 2 minutes. And again, I will emphasize, it is almost a Herculean task to be effective with CPR or running a code if it is just you and your partner. It's extremely difficult for you to be effective with just 2 of you. So you need at least 3 or 4 persons. So when it comes to running a code, it has to be a coordinated effort. It has to be. The fire service assists private services assist the fire service. It has to be coordinated. Now, opening the airway in adults. Head tilt chin lift maneuver used when there is no indication of spinal injury and patient has not sustained trauma. Jaw thrust maneuver used if spinal injury is suspected. Place your fingers behind the angles of the patient's lower jaw and move the jaw upward. Recovery position. Place the patient in recovery position if unable to breathe on the if they can, not if they are unable. So that's an error on the slide. Place the patient in recovery position if they can, if they are able to breathe on their own. No signs of injury to spine or hip or pelvis is present. Breathing. Lack of oxygen or hypoxia combined with too much carbon dioxide in the blood. Hypercarbia is lethal, and the more carbon dioxide present in the body is the more acidotic the blood or fluid is going to become. So the pH is going to become very acidic if there's too much carbon dioxide. That's not good for the brain. Ventilation should be delivered over 1 second. Prevents air from being forced into the stomach, resulting in gastric distension. Providing artificial ventilations. Use a barrier device when administering ventilations in the pre-hospital environment. Hyperventilation may cause increased intrathoracic pressure. We don't want to increase the intrathoracic pressure because it can interfere with venous return and it can interfere with perfusion to the brain. Stoma ventilation, stoma opening that connects the trachea directly to the skin, Use a pediatric mask to ventilate through the stoma. Gastric distension. Artificial ventilation may result in the stomach becoming filled with air, likely to occur if you hyperventilate the patient, give slow, gentle breaths. If massive gastric distension interferes with adequate ventilation, contact medical control. You may have to turn that patient on their side, create pressure on the abdomen, clear the air passage as the vomitus comes up or fluid comes up, and then go back into your BLS protocols. One rescue adult CPR. When providing CPR alone, provide a continuous cycle of 30 chest compressions followed by 2 artificial ventilations. So that's a ratio of 30 to 2. 2 rescue adult CPR is less tiring and facilitates effective chest compression. Critical to switch rescuers during CPR to maintain high quality compressions. And if it's two of you are working that code, you don't have anybody to switch between you and your partner. Not going to be very effective. Second rescuer should apply AED, set up airway adjuncts, insert an oropharyngeal airway as needed. Crew resource management. Way for team members to work together with team leader to develop and maintain a shared understanding of the emergency situation. Each team member is responsible for maintaining situational awareness of the patient's current condition. Team leader is responsible for listening to any crucial information and incorporating it as needed. This utilizes the PACE mnemonic. So probe, you're going to probe for issues, right? Probe for issues. Alert, when you find issues, you bring that concern to your team lead. The team lead will identify challenges. So as a team lead or a part of the team, you need to look for issues that can be challenging and point them out. And think about how these issues can be addressed as a team. If the emergency, if you identify an issue that you think is going to cause serious complications immediately, then you need to immediately bring that to the attention of the rest of the team. So teamwork is going to be very important when running a code. Code team member roles, you have ventilator, active compressor, on-deck compressor, other support personnel. Code team leader must know and be able to expertly perform each skill. Responsible for ensuring everything gets done at the right time. Again, I will emphasize 2 persons running a code is not effective. You need at least 3 or 4 persons to run a code in the field and run it properly. Important component of caring for cardiac arrest patients. If an effective cardiac rhythm is restored in the field, provide immediate transport. Monitor the patient's blood glucose level and ensure effective ventilation. Always leave AED pads in place. For post-cardiac arrest care, we need to optimize ventilation and oxygenation. Treat hypertension if the systolic blood pressure is below 90 millimeters of mercury, and you're going to be guided by your protocol. Advanced critical care in the ED will include the patient is going to get a 12-lead ECG to rule out a STEMI or AMI. There's going to be consideration for coronary reperfusion treatment, targeted temperature management for comatose patients will also be considered. Now, devices and techniques to assist circulation. So they have started to utilize what is called active compression decompression CPR. And basically, the AC/DC device is like a suction cup that you put on the chest, and you're actively pushing the chest down and pulling the chest up. And it is used with an impedance threshold device or rescue pod. And what this method of CPR, doing CPR, does is it reduces the intrathoracic pressure and intracranial pressure when the recoil of the chest occurs. And what this does is it will encourage better venous return and better blood flow to the brain, and as an extension the rest of the body. So that's the AC/DC and ITD device. You can read up on it. Also, we have the mechanical piston device and the loading distributing band. These are devices that will perform compression on the patient, so it frees you up. And if it's two of you working, then your organization should consider getting a compression device so that your hands are free. It is the gold standard for doing CPR in a moving ambulance. So this is a gold standard. If CPR is required in the back of a unit, a compression device is what is going to perform the compression. If a compression device is not available and rescuers are performing the compression, then you're putting the rescuers at risk and the compressions will not be effective. Again, things you can read up on. Infant and child CPR. Cardiac arrest in children usually follows respiratory arrest, triggers hypoxia and ischemia. Children consume oxygen 2 to 3 times as rapidly as adults. Focus on opening the airway and providing artificial ventilations. Determine responsiveness. Never shake a child to determine responsiveness. Unresponsive apneic pulseless child. Remember, for your infants, newborn, and neonates, they don't need to be pulseless. The pulse just needs to be below 60. Perform CPR, beginning with chest compressions for 5 cycles, then call 911 and retrieve an AED or activate your emergency response system. Check for breathing and a pulse. Visualize chest for signs of breathing. Palpate for a pulse in a large central artery. In infants, palpate the brachial artery. Chest compression. Place infant on a hard, flat surface. Remember now, they are top heavy, so you may have to elevate their shoulders to get the head in sniffing position. We don't want to hyperextend their head because it will close off their ear passage. Use only 2 fingers to compress the chest, coordinate compressions and ventilations. Infant and children CPR. Foreign body obstruction of the upper airway of infants and toddlers is very common. Open the airway using the same techniques used for an adult. If the child is unresponsive but breathing, place in the recovery position. Provide rescue breathing. If the child has a pulse, breathe one breath every 3 to 5 seconds. If child doesn't have pulse, 2 breaths after every 30 compressions. Interrupting CPR. So when we should consider interrupting CPR. If ALS is not available at the scene, provide transport based on your local protocols while continuing CPR. Rendezvous en route. Try not to interrupt CPR for more than a few seconds except when necessary. Maintain a chest compression fraction of at least 60%. When not to start CPR. 3 general exceptions. If the scene is unsafe, if the patient has obvious signs of death, rigor mortis, dependent lividity, petrification, mortal injury. If the patient has a do not resuscitate order or no CPR order. Usually only applies when the patient is in the terminal stage of an incurable disease. Always start CPR if in doubt, if any doubt exists, and the patient can have a DNR that it says not to resuscitate, but it's more specific to ACLS. So BLS can be done, but they don't want any ACLS. So these DNRs can be very specific. When to stop CPR. Once you begin CPR, continue until, so we will use the acronym STOP. Patient starts breathing and has a pulse, that's the S. T, the patient is transferred to another trained responder. O, you are out of strength, physically unable to continue. P, physician who assumes responsibility for the patient directs you to discontinue. Foreign body airway obstruction in adults. Airway obstruction may be caused by relaxation of throat muscles, vomited stomach contents, blood, damaged tissues, dentures, foreign bodies. Large objects that cannot be removed from the airway with suction should be swept forward and out with your gloved index finger. Use suction as needed to keep airway clear of thinner secretions. Recognizing foreign body obstruction. Mild airway obstruction, encourage patient to cough. Responsive patient, patient grasps the throat. Unresponsive patient, follow your BLS protocol. Removing a foreign body obstruction in an adult, abdominal thrust or Heimlich maneuver may be necessary. Chest thrust for pregnant and obese patients. That's if your hands can wrap around the patient. Responsive patients who become unresponsive, still on foreign body airway obstruction in adults, begin CPR starting with chest compression. Every time you go to give ventilations, make sure you check the upper airway for the object. Unresponsive patients begin CPR, never perform blind finger sweeps on patient. Foreign body airway obstruction in infants and adults, usually caused by a foreign body or infection. In patients who have signs and symptoms of an airway infection, administer supplemental oxygen. Humidified oxygen will be beneficial to these patients if needed, and immediately transport the child to the ED. Previously healthy child eating or playing who suddenly has difficulty breathing has probably aspirated a foreign body. Responsive child, give abdominal thrust in an upward direction. Repeat until the child expels the foreign body or becomes unresponsive. Unresponsive child, if the child becomes unresponsive, position the child on a firm, flat surface and give 30 chest compressions. A child older than 1 year with an airway obstruction is managed in the same manner as an adult. For responsive infant, perform back slaps and chest thrusts. Hold infant face down with body resting on your forearm. Deliver 5 back blows. Turn infant face up and compress chest with 1 finger or 2 fingers. Unresponsive infants, begin CPR, starting with chest compression. Look inside infant's airway each time before ventilating. Remove the object if seen. Now, special resuscitation circumstances. For opiate overdose, Administer naloxone through local protocol. Standard resuscitative measures take priority over naloxone administration. So if you suspect that the patient overdosed on an opioid, don't get caught up in giving the medication when CPR is necessary. So CPR still needs to be done, and then the medication is administered once it's ready to be administered. Patients who have a pulse but are not breathing, bag mask ventilation is most critical treatment, followed by administration of naloxone if available. Very important slide. Very important information. For your pregnant patient, this is also very important. Cardiac arrest in pregnancy. Provide high quality CPR and relieve pressure of the aorta and vena cava. So somebody's gonna have to push that fundus away from the vena cava and the aorta while chest compression is being done. So manual displacement of the uterus while CPR is performed is gonna be necessary. The patient may have to be at an angle. So you may have to create an angle with this patient, meaning elevation of the upper body, because if they are too flat, it can interfere with how you bag the patient. These are some things to consider. Grief support for family members and loved ones. When death appears imminent and resuscitative efforts are unsuccessful, make the family members aware the patient is not responding to treatment. Discuss with them what is happening so they may be better prepared for the inevitable. Keep family members informed throughout the resuscitation process. Education and training for AEMT. Practice CPR skills frequently, often using mannequin-based training. Very important slide. So if you're working in a system that you're not running codes often, or you're not guided by proper protocols and medical direction, you need to practice your CPR skills frequently. And I would say every month you should be practicing a code, or you're gonna run a code. If you're not practicing, when it does happen, you're gonna make a lot of mistakes and the patient ultimately suffers at that point. So if you're not doing it often, you need to practice the skills, and you need to practice a team approach, not an individual approach, a team approach. And as an AEMT, you should be able to lead a team, right? So you should be able to instruct EMTs in terms of what you want them to do and how they're going to do it and how you will function as a team. So practice CPR skills frequently, often using mannequin-based training. Don't wait until every 2 years when your CPR cards are expired to start doing that. That doesn't benefit the patient. Use high fidelity mannequins for CPR training. Education and training for the public. Facilitate the training of lay people in critical skills of CPR and AED operation. So it's very important that the people within your primary service area know how to do proper chest compression. They don't even need to know how to do proper ventilation. They need to know how to do some good chest compressions and how to use an AED, or what is the role of an AED. The more information they know, the better your interventions will be for the patient when they call you. So if they call you and they don't know how to do proper chest compression, that's going to make your job difficult, right? So if they're trying to do something based off of what they saw on TV or learn, it's not going to be done properly, and it's going to make your job more difficult. So educate the people within your primary service area, whichever way you choose to do that. Go to the community or invite the community to the organization and do some work with them. Your agency should make an effort to educate families to recognize cardiac arrest and train them to perform compression-only CPR. They just need to be able to do good chest compression. It's a lifesaver. And that brings us to the end of this